Good afternoon, doctors. Welcome you on this webinar on the role of Oseltamivir in flu management. This webinar, as you know, is brought by Hetero Healthcare, an innovative pharmaceutical company. Hetero Healthcare, the journey began in 1993. We have 30 years of excellence and 36 state-of-art manufacturing facilities, 300 plus products in portfolio and presence in 126 plus countries. We have 21,000 employees and we are almost the largest closely held pharmaceutical company in India. We are amongst the largest manufacturers of ARV, APIs, and FDFs in the world, and we have Asia's largest API manufacturing facility at SCZ Complex, Visakhapatnam, Andhra Pradesh. Hetero Healthcare is a 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and we have distinction of bringing 4 biosimilar products to market within 5 years of initiation. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirus, offered Oseltamivir, Favipiravir, and Remdesivir to the patients, because of which in August 2020, they received an award of Pharma Excellence for COVID drugs. Today's webinar, role of Oseltamivir in flu management, we have got moderator Dr. Pramod sir. Welcome, sir. And speaker Dr. Ketan Shah and Dr. Ravindra Chopra. Welcome, Dr. Ketan. Welcome, Dr. Ravindra. Dr. Pramod sir is Professor of Pediatrics, D.Y. Patil Medical College, Pune, President IIP 2016, Steering Committee Member GAVI CSO 2016 to 19, Chairman Mini Recipe Module IIP, author of book Cophology. Welcome, Dr. Pramod. Dr. Ketan Shah is President Surat Pediatric Association 2003, National Trainer ATM, PSPP, ASK, IIP, CPIDC, How Do I Investigate, National Antibiotic Practice, National TB Module, Rapid Module. National Secretary, Pediatric Rheumatology Chapter 2005-6, Organizing Chairperson, National Rheumatology Meet 2006, EC Member, Gujarat Pediatric Association 2014-2019, and EC Member, ID Chapter 2013. Welcome, Dr. Ketan Shah. Dr. Ravindra Chopra is MBBS MD, Chief Pediatrician and Director, Muskan Children's Hospital, Surat. Welcome, Dr. Ravindra. And with this brief introduction, I hand over the session to Dr. Pramod for further deliberation. Over to you, sir.
Thank you, Dr. Prashant. And we are going to discuss about a very important topic today, and that is about one naughty virus. This naughty virus is the influenza virus. And I must tell our audience that all the RNA viruses are very naughty, like COVID-19, influenza, RSV, because they change their structure very often. And in case of influenza, everybody knows that every year we have to change the strains in the vaccine and give a different vaccine to the children. So it is very important that we are aware of all the information related to influenza. And we all know that in the monsoon season, which is going on right now, so many children are coming to us with respiratory infections like RSV and influenza, and not only respiratory but also other viral infections like dengue are also commonly being seen. And I always say that, if there are so many viruses like rhinovirus, then RSV, adenovirus, and this influenza, parainfluenza, it's really, really very difficult for a pediatrician to identify as to what is the type of virus that he is facing in front of him. And jokingly, many times I say that even Rajnikant cannot identify what is the type of virus, So it is very important that we try to understand what is the clinical presentation of some of these prototypes. And we will discuss about the virus. We will discuss about the clinical presentation of the virus. We will also discuss about the management plan, the role of Oseltamivir, and also discuss some cases which our colleagues have seen in the practice. I am fortunate to have Dr. Ketan Shah and Dr. Ravindra Chopra for this particular discussion. And in the initial part, both of them will discuss about the disease and the clinical presentations and the other aspects of the disease, followed by a brief discussion related to the queries of our audience. So, Dr. Ketan, I request you to start with your presentation, and later on we will have the questions and answers, and both of you can answer those questions at the end of the discussion. Thank you.
Thank you, sir, for a very nice and brief introduction about us, about Rajnikant, and about Oseltamivir also. Thank you, Dr. Prashant and Dr. Hetero Healthcare for giving us this opportunity. We have with us Dr. Ravindra. He's a very good academician of Surat, very nice and sober personality who has been always an helping hand whenever there is an academics. So our goal of discussion is use of Oseltamivir in flu management. The main content of discussion would be healthcare challenges in monsoon and their diagnosis, influenza and its complications, clinical evidence of oseltamivir uses, and guideline recommendation for empirical use of oseltamivir. As we all know, the monsoon would have many challenges, including dengue, chikungunya, malaria. Fortunately, the incidence of malaria has significantly gone down, but the respiratory illness, they are very common in monsoon, which includes influenza-like illness, H1N1, severe acute respiratory illness, and COVID-19. We do get scattered cases of COVID-19. However, the seriousness is not that much as we had seen in the pandemic. India and influenza disease. What we know about influenza in India, which season does it come, and what is the correct time to vaccinate? Let us look at some of the statistics. This picture is taken from Purple Book of Indian Academy of Pediatrics. And for a pediatrician, we know Purple Book is like a Bhagavad Gita for vaccination. This is from page number 324, which indicate that from 2014 to 2019, we had a peak of influenza from January to April and June, July to October. There are good number of cases which picks up in February, March and July, August. Again, the global burden of disease 2017 clearly indicates that influenza-like lower respiratory tract infection, there were more than 5,88,000 hospitalization and 26,000 death has been reported globally. In India, the year-wise number of cases and death from 2017 to 2022 up to November 22. In 2017, the number of cases were 38,800 and death were 2,270. And in 2022, 12,000 cases has been reported and 399 death. So there is no doubt about existence of influenza in India. It is like Rajnikant, who is everywhere available. Same way influenza is available all over India. Almost 5 to 10% of all ARI are due to influenza. 10 out of 100 child per year suffer from influenza. The two different studies from North India indicates that 178 to 180 children per 1,000 per year below 1 to 2 years, they do suffer from influenza-like illness. The influenza-associated respiratory infections are 33 to 44 per 1,000 children per year. And in 2009 pandemic, 22.8% positive cases were seen in pediatric population for influenza. And in 2015 up to March, 30,000 cases has been reported and 1809 death was reported. In northern India, the peak is between January and March. In central India, it is July to September. And in southern India, September to November. So we get two peak, winter and monsoon in India, and the pattern of circulating strain varies year by year. This is again a graphic representation of influenza in India. The first side shows left side. The cases of influenza infection are 28,000 in 2019, and in 2015 it was 4,000 only. So the number of cases are increasing. The death on the right side shows that in 2019, almost 1,200 death has been reported because of influenza. And there has been various studies which shows that influenza does exist. This is one of that study. I request Dr. Ravi to elaborate the study. Over to you, Dr. Ravi.
Thank you, Dr. Ketan. You already nicely narrated the influenza epidemics, influenza seasonality, and incidence of influenza in our country. But there was a time when we people used to think that influenza does not exist in India, and there is no flu seasonality in our day-to-day practice. This was a myth-breaking study, and this was done at Department of Virology at King's Institute of Preventive Medicine Research in 2019, and the study incorporated 36,670 specimens, and they were subjected for influenza analysis. And hence, we came to know about the influenza incidence over a period of 7 years of the study. It was found that influenza positivity was eventually there, and it started with the onset of monsoon, and the peaks are during the post monsoon months. So this was a regional study from Tamil Nadu. So the main peak in southern hemisphere, as we now know, that it takes place during this kind of a season. So this was one of the eye opener study, and now we all know that there is a seasonality between northern hemisphere and southern hemisphere strains, and there is a winter strain and there is a monsoon strain, and we have different vaccines for that.
Thank you, Dr. Ravi. So there is no doubt about the existence of influenza in India. Study has proved, our purple book has already shown the data. Influenza does exist and the strain also varies. And we all know that influenza is one of the most common infectious disease caused by flu virus, highly contagious, occurs in seasonal epidemics and manifests as an acute febrile illness. The disease severity varies from mild to severe, and serious outcome of flu infection can result in hospitalization or death. So far, so microbiology is concerned, influenza is of three types, A, B, and C. Over to you, Dr. Ravi. Can you elaborate the microbiology of influenza?
Yes, so as we all know that influenza is a RNA virus, and as Dr. Pramod already mentioned that this is a RNA virus, a very notorious virus. So this being a RNA virus, this virus is classified into three categories depending on their nucleoprotein and M-capsid protein. So M-capsid is a capsule of the virus which is present only in influenza A virus, whereas other viruses lack it. So there are four kinds of influenza virus: A, B, C, and D. So most relevant virus and most significant virus which causes frequent epidemic is A virus, and it is also responsible for global pandemics which we already had. Influenza B virus is mainly infecting humans only, and it causes local epidemics, and there are no subtypes. Only there are two lineages of this virus, like Victoria and Yamagata. Influenza C virus, it infects human and swine, and it generally causes very mild respiratory infection and generally not encountered in our day-to-day practice and considered non very significant. Influenza D virus only affect cattle. So we come to influenza A virus. There are many subtypes depending on heme agglutinin and neuraminidase. So there are H1 to 18 and N1 to 11. So there are many subtypes like H1, N1. Different permutations and combinations are possible, and these kind of combination permutation leads to antigenic variation. So there are two kinds of antigenic variation in this virus, which is one is a drift and another is a shift. So drift mutation are minor antigenic mutation, minor genetic information change, which escapes our immune system, and hence we have less immunity against the previous virus, and probably we are susceptible for infection. That's why we have to take different vaccines in different season, or we have to take annual influenza vaccine. Shift is a major viral reassortment of the virus. So it is kind of a entirely new virus. And it escapes our immune system totally because there is no memory against this virus. And this is responsible for major pandemics that we had and we may have coming years ahead.
Thank you, Dr. Ravi, for nicely elaborating ABC virus and the drift and shift. Drift and shift phenomena are like Rajnikant, changing the shape and size and creating a trouble to the general public. So flu virus, it spreads very fast, even up to 6 feet distance. It can spread. It spreads by droplet and it spreads by coughing, sneezing, or even talking. The droplets can land in the mouth or nose of the people who are nearby or possibly be inhaled into the lungs. And people should stay away from the affected person and stay home if sick. It is also important to wash hands often with soap and water. And most healthy people can start transmitting the disease 1 day prior to the onset of the symptoms and up to 5 to 7 days after becoming sick. Children may pass the virus for longer than 7 days. There are symptomatic differentiation of influenza-like illness, H1N1, SARI, and COVID-19. Clinically, it is difficult to differentiate, but however, there are some clues to differentiate them. I'll request Dr. Ravi to briefly describe the differential diagnosis of these all four diseases. Over to you, Dr. Ravi.
So it's easier said than done, and differentiation is very, very difficult. There is a broad group which we call as ILI. It's influenza-like illness. So it is a broad group. The terminology has given to the any patient who is presenting with acute respiratory illness with fever it's more than 100.4 with sore throat and respiratory symptom. So ILI generally present with fever, myalgia, cough, lack of energy, and sore throat. And other symptoms may or may not be there in ILI. Whereas H1N1 is mainly all other features with ILI, but generally it's a more of a respiratory, severe respiratory involvement with the breathlessness or respiratory distress and a lot of body ache and headache. Whereas SARI is mainly limited to respiratory system only and it leads to the severe respiratory involvement. COVID-19 can have every symptom, but the predominance of loss of smell and loss of taste probably leads us to diagnosing COVID-19 more often than any other ILI kind of illness. So there can be symptom overlap between all these illnesses, but as we know that COVID-19 mainly have respiratory illness with loss of smell and taste, and there are other systemic signs like diarrhea or other systemic involvement is common in COVID-19, whereas H1N1 and SARS is generally limited to respiratory and general systemic debility.
Thank you, Dr. Ravi. Just to narrate a one case, yesterday only I had an adolescent female child came to me with a fever for 5 days, cough, cold, low WBC count, normal CRP, but she has predominant symptoms of loss of smell and loss of taste. And we know that today is the Chandi Padwa, which is the great festival of Surti. She told that, uncle, I am not able to taste the ghari, and ghari is a typically a special Surti food. So do anything, but I want to taste the ghari this year. I'm not even able to take the smell. So loss of smell and loss of taste, severe prostration probably represent COVID-19. We have admitted this child. However, due to financial constraint, the testing has not been done. When any child comes with the respiratory symptoms, we often look at the warning signs. And these warning signs are always taught into the PALS course, has been written in the Nelson textbook also. We follow the ABC command. Anything compromising airway, breathing, and circulation. Child coming with a respiratory distress, grunting sound, maybe having a cyanosis, is a severe impending respiratory failure. In flu disease, if child has a respiratory distress, coughing, severe prostration, vomiting, tachycardia, not able to stand, excessive crying, or a very dull child, not crying at all. These all are warning signs in children and even in the adult. Difficulty in breathing, tachycardia, hypotension, sudden dizziness, persistent vomiting, confusion, disoriented. These are the warning signs of a respiratory serious illness which may be disseminating or causing multi-organ involvement. So looking to these scenario and history presentation, now we go to the diagnosis. Do we have any diagnostic modalities available for diagnosing influenza-like illness to specific influenza disease? Over to you, Dr. Ravi. What are the diagnostic modalities available for influenza?
So, first are the routine diagnostic tests to differentiate other monsoon illnesses like dengue and other illnesses, which sometimes they confuse us with influenza. So, we can go for routine counts and dengue tests, etc. But when we come specifically for influenza, there are four kinds of tests available. One is a rapid antigen test, which is not standardized and no longer used nowadays. The most common test used is a kind of a PCR. Two kinds of PCR are there, non-typable and typable. Non-typable PCR, generally in the form of flu panel test, where we depict influenza A virus, B virus, COVID, and RSV. And it is the most common test which is used in day-to-day practice, relatively uh, cost effective. And second is a typeable PCR, which is always a part of multiplex PCR in our setup. And it's quite expensive, but it is the gold standard test. And actually, the gold standard is a viral culture, which is only meant for research purpose mostly, and generally done by Virology Institute to typify the virus rather than diagnosing it, because it takes a lot of time. And sometimes there may be a rising antibody titer which can be retrospectively used to diagnose influenza virus. So, if we talk about complications of flu, flu being mainly a respiratory illness, so adjacent respiratory complications are the common complications like bronchitis, pneumonia, and severe respiratory distress (ARDS). Then the adjacent respiratory tract like sinusitis, otitis media, very common in kids, like many of kids with flu I see during coexisting ASOM, AOM, or on follow-up they come with otitis media. It's very common complication. Then other systemic involvement in the form of myocarditis, and then muscle involvement, rhabdomyolysis or myositis. Then very rarely encephalitis or encephalopathy, and one very dreaded condition like Ray's syndrome, kind of encephalopathy, which we used to see in past quite often, but somehow with awareness we are not seeing these cases very often, or very hardly we see these kind of cases. So these kind of complication takes place in kids, whereas in adults it is mainly exacerbation of the existing disease. Like if the patient is having diabetic complication, then exacerbation of diabetic complications, and then chronic renal disease, heart failure, and other systemic involvement, they can worsen, and it can lead to hospitalization.
Thank you, Dr. Ravi, for nicely elaborating the complications of flu-like illness. Now let us go to the management of influenza. The antiviral therapy with oseltamivir when it is indicated. So primarily the treatment starts with supportive, bed rest, increased fluid consumption, cough suppressant, round-the-clock paracetamol, if needed, NSAID drugs for fever and myalgia. Most patients will recover in 3 days. However, malaise may persist for weeks. Patient would say कि सर बहुत weakness लग रही है, बहुत कमजोरी लग रही है, कुछ tonic दे दो या bottle चढ़ा दो. This is what it happens for almost 1 or 2 weeks after influenza, and severe cases may require hospitalization. Clinically, we divide influenza-like illness into category A, B, and C. A is a mild disease. where the patient is walking in, comfortable, fever, watering of eyes, running nose, mild throat congestion, and no other system involvement. Category B is more than A, where you have a more severe coughing, patient may have a vomiting, weakness, maybe having a dehydration, and a very high fever. Category C, further worsening of the B category, where you have a respiratory compromise, or you may have other system involvement, you may have a hypoxia. So these are the category C patient. Now antiviral drugs for influenza, they are divided into two groups, neuraminidase inhibitor and adamantinase, which are M2 ion channel blockers. Neuraminidase is one of the enzyme present in the virus. These drugs, they block the viral enzyme, which is critical in releasing new viron from the infected host cell. These drugs are active against A and B. Oseltamivir is a prototype drug. It has been well studied and well established. Zenamavir is another drug, not well studied and not well established. In adamantinase group, they interfere with hydrogen ion channel activity of the influenza A virus, thus blocking its entry into the host cells. They are active only against influenza A virus. The examples are amanitin and remanitin. The preferred drug is oseltamivir. It is a potent and selective inhibitor of the neuraminidase enzyme. It is a prodrug which is converted to oseltamivir carboxylate in the liver. It inhibits influenza virus replication and reduces its pathogenicity. It prevents further spread of infection, and it is effective against all strains of influenza A and B, including the avian H5N1, H1N1, and H9N2 strain. This is some pictorial presentation. How does the drug act? The upper part shows the viron. There is a neuraminidase enzyme. With the help of neuraminidase enzyme, the new virus is formed and the viral replication continues. The lower part shows that these neuraminidase inhibitor drug like oseltamivir will prevent the formation of new virus. So it halts the viral replication, thus preventing the viremia, preventing the toxemia and complications. It has been the first oral neuraminidase inhibitor and it is approved in more than 100 countries. Approval is from FDA, CDC, American Academy of Pediatrics, and even by the Indian government. So these were something about the oseltamivir. And the dosage and recommendation, this is the table which we all should remember. The capsule is available in 75 milligram. The syrup is available as a 12 milligram per 1 ml. We use it for the treatment or for chemoprophylaxis. The treatment for adult is 75 milligram BD. If the child is less than 15 kg, the dose is 2.5 ml BD and the prophylaxis is 2.5 ml once a day. 15 to 23 kg, it's 3.75 ml BD. 23 to 40 kg, it's a 5 ml BD. And more than 40 kg, it's a 6.25 ml BD. Infant or 2 weeks to less than 1 year of age, the dose recommendation is 3 milligram per kg BD dose. It is safe to use in the infancy also. Prophylaxis not recommended in infancy, but safety profile is very good so far as oseltamivir is concerned. So we learnt about the epidemiology, we have learnt about the microbiology, we have learnt about the diagnostic test, we learnt about the complications and pharmacokinetics of oseltamivir. Let us look at some real case scenario which had been seen by Dr. Ravi. Dr. Ravi, over to you.
Yes. So these are my routine indoor patients, which I'll be sharing with you. And I'm sure that every one of you might have encountered such patients. One of them is Ishani. She is a 6.5-year-old female child, resident of Vesu, Surat. The child was immunized for routine childhood vaccination, but had not taken annual influenza doses. The child presented with high-grade fever. It was 103 to 104 degree Fahrenheit with cough and cold for last 2 days. Throat pain with great severity for 1 day. And before presenting to the hospital, child had breathlessness for last few hours. There was no significant past or family history, though according to the mother, many kids in the school were suffering from cough and cold. Child was well nourished, febrile with 104 degree Fahrenheit oral temperature, with mild tachypnea with respiratory rate of 42 per minute with mild retractions and a heart rate of 150 per minute, blood pressure 90 by 50. Child was having a saturation of 93 to 94% on room air. Her throat was grossly congested with nasal watery discharge. Chest had shown bilateral crepes and rest all systemic examination was normal. So after stabilization of the child, we started investigating her. She had a normal CPC with normal hemoglobin of 11.9 and total count of 5,890, mainly polymorphic with a normal CRP of 6.7. We did chest X-ray, which was showing bilateral perihilar opacities and prominent bronchovascular markings. Considering above finding with a sick child and a respiratory multiplex PCR was sent, which was positive for H1N1. So during the course of stay in the hospital, child was started initially on IV fluid and oxygen inhalation, and we had a strong suspicion of influenza. So we started Oseltamivir, which was continued after the influenza report. Child continued to have high-grade fever for the next 24 hours. So it was requiring paracetamol infusion repeatedly in the first 24 hours. And after 24 hours, there were a few breaks in the fever and fever spikes started declining. Respiratory distress in the form of retraction and tachypnea also declined, and child was quite comfortable after 24 hours and gradually weaned off from oxygen in the next 24 hours. At around 72 hours, child was afebrile with no respiratory distress and little bit of weakness and cough persisted. And after 72 hours, child was discharged on oral oseltamivir and some decongestant antihistaminics and advised to follow. So this case depicts the rapid progression of disease, like in a span of 2 days from mild cough and cold to severe respiratory illness, progressing to respiratory distress and oxygen requirement, and a very rapid recovery after starting the specific treatment and with proper diagnosis. So this case depicts the proper diagnosis and prompt treatment with oseltamivir actually. So my next case is Prishit. He is a 10-year, 4-month-old male child and is a known case of seizure disorder. The child was on oral valparin and not had any seizure for the last 1 year, more than 1 year, and was on tapering doses of planned to taper valparin actually, did not start tapering. The child presented with persistent cough for 3 days, fever third day for lasting almost around every 6 to 8 hours with 102 to 103 spikes, with severe weakness, body ache, heaviness of the chest. And there was one episode of stiffness of both the upper limbs and uprolling of eyeballs, which was very transient. So child was admitted in emergency department. His weight was 33 kg, height 137 centimeter, and temperature 101 degree Fahrenheit. Mild tachycardia, pulse 137 per minute, respiratory rate 38, with a normal saturation of 98% on room air. Blood pressure 120 by 70, and there was no respiratory distress in the form of retraction or grunting. Child was fully conscious and oriented, and there were no abnormal movements during the hospital admission. Throat was grossly congested, chest had shown bilateral conducted sound as well as a lot of rhonchi. Other systemic examination was normal and CNS was not showing any focal deficit. On investigation, child CBC was showing hemoglobin of 12.2, total count 4,900 with mainly polymorphic. CRP was 18.6 borderline, and X-ray had shown a bilateral parahilar prominence, which will be showing just now. Considering all these things and seasonality, we sent a flu panel which was positive for influenza B virus. So this you can see the X-ray of the child which showed parahilar prominences and little bit of hyperinflation. So on admission, child was started on IV fluid and amoxiclav with levosalbutamol nebulization. Oral oseltamivir was added after the report. Child improved significantly after 24 hours, though the nausea, lethargy, and cough persisted for a couple of days, and there were no further seizures after the admission. Child discharged on day 3, the third after the third day, on oral oseltamivir and supportive treatment. So this case highlights that the child was very stable, known case of seizure disorder, was very stable on anticonvulsant therapy, and the seizures got precipitated by influenza illness, uh, even on medication. So after a long interval of maybe 1 year. So this is a third case. Avdi, 14-year female child, presented with fever for 6 days. Initial 2 days, very high grade fever and then decrease in intensity. Child has been traveling to Rajasthan, so did take only oral paracetamol and had not sought any medical opinion. There was a worsening cough, severe lethargy, and unable to stand. When the child presented to us, she was like totally with the lap with in the relative's lap and having severe dizziness. There was family history of fever and cough in two of the family member at native place. Child was dull looking, sick, febrile with temperature of 101 degree Fahrenheit, quite dehydrated with blood pressure of 90/60, respiratory rate 32, and such normal saturation of 98% on room air. Heart rate was 146 per minute, and there was no respiratory distress. Throat was severely congested, conjunctiva congested, and there was evidence of stomatitis in the child. On chest auscultation, there were fine basal crepes, and rest of the systemic examination was not remarkable. So we started with supportive treatment and investigated the child. Hemoglobin was 14.2. A child was little dehydrated and there was a hemo concentration. Mild leukopenia with TLC of 3,400 and neutrophils of 45% and platelet of 1 lakh 69,000. CRP was 10 and chest X-ray had shown bilateral lower zone reticulated pattern or haziness, mainly parahilar. Biofire was done, which showed influenza A, H1N1. So, on the course of hospital stay, child was started on IV fluid, IV ceftriaxone, because child was very sick looking at the time of admission, and we started with nebulization with oxygen and added on oral oseltamivir. And after rehydration, child showed significant improvement in weakness and lethargy, and there was improvement in GC. On oseltamivir, after 36 hours of treatment, child improved dramatically with improvement in fever and respiratory sign. Child was active, agile, and eating well, and hence was discharged after 3 days of on oral oseltamivir and supportive treatment. So this case, as we know, highlights that though the child presented on later on the course of disease, maybe 6th or 7th day of illness, and was having very severe symptomatology, responded very well with oseltamivir. Generally, we believe that the oseltamivir works only in the first 48 hours, but it does work in the later stages of disease also. Thank you, Dr. Ketan.
Thank you, Dr. Ravi. These all three cases definitely elaborate the utility of oseltamivir in suspected case of influenza-like illness. Early onset symptoms, early treatment, early recovery. Child with comorbid condition, we need to use these oseltamivir, and a patient coming on the later stage also, just give benefit of late oseltamivir starting, and that will also have a fast recovery. Same way in these case scenarios, infant 2 weeks old, fever, cough, cold, all family members have a cough, cold, and fever. One of them admitted for acute respiratory infection. So this is likely to be highly contagious influenza-like illness, and 2 week old infant is definitely at risk. Here, the empirical use of oseltamivir is justified. A known case of nephrotic syndrome, getting respiratory infection with myalgia, fever, cough, cold, who is not vaccinated for influenza and even pneumococcal, he is on steroid. This is a real candidate for empirical use of oseltamivir. 9 years, known case of asthma, had a fever, cough, running nose, not very sick, but still, when there is a family history of ARI, child is having a category A or even category B of the symptomatology, he is a candidate for early starting of oseltamivir because asthma and flu are deadly combination. They can aggravate, exacerbate both the symptomatology. Asthma patient, they are known to create more trouble with influenza, and influenza getting more respiratory distress in a case of asthma. So these are high risk category. Oseltamivir is a wonderful drug for walking pneumonia and early onset severe symptoms. There are clinical trials narrating that the benefit of empirical use and early use of oseltamivir is very useful. One of these study, which has included 3,564 subjects who had influenza-like illness, and they were enrolled into double-blind trial. It has been found that the patient who has received oseltamivir, the use of antibiotic was significantly reduced. The influenza-related lower respiratory complications resulting in antibiotic therapy has reduced to 55%, and hospitalization were 59% less when oseltamivir was used. So this study definitely highlights use of oseltamivir in the early cases. However, the severity of pneumonia due to H1N1 by early oseltamivir has been described in this study. This was a retrospective study of 442 patients. The median time of starting oseltamivir was 5 days. They were divided into 4 categories: less than 2 days, 3 to 7 days, 8 to 14 days, and more than 14 days. It has been found that if you start early oseltamivir, the probability of severe pneumonia significantly reduces. And even if you start in the midway or even in the late stages, the recovery is comparatively good than not starting oseltamivir. Here, the patients with a shorter time to oseltamivir administration were discharged earlier from the hospital. So if you start early oseltamivir, even in our practice, we had seen that any patient coming with category B, you start oseltamivir, and second, third day, patient is afebrile and getting discharged. Yesterday only, I have admitted one patient who had 104 fever with 2 episodes of febrile convulsion with normal count, with cough, cold, and family history. I have started oseltamivir empirically, and today patient is totally afebrile. Maybe tomorrow will be discharging them. So the hospitalization also reduces significantly. This is about the prophylaxis. The prophylaxis duration is 10 days, and when you have a community outbreak, the prophylaxis is up to 6 weeks, and for immunocompromised patient, it is up to 12 weeks. The guideline recommendation are from WHO. Empirical treatment is strongly recommended. Treatment should be started as soon as possible. Lab confirmation is not necessary. Negative result does not rule out H1N1. and empirical treatment is justified. In high-risk individual, immunocompromised child, we have to use oseltamivir as a presumptive treatment. This has been recommended by Ministry of Health and Family Welfare, Government of India, that empirical use of neuraminidase inhibitor is important to reduce the risk factor of influenza. In adult who had a community-acquired pneumonia, who test positive for influenza, definitely we have to add an antiviral drug oseltamivir along with antibiotic. Nowadays, we do a biofire test. Even if you have a very serious strep pneumonia or staph pneumonia or even a mycoplasma, and if the biofire shows positivity for influenza, we have to add oseltamivir, and this does give a faster and better recovery. So empirical use sometimes recommended, but if you have a proved case of influenza with community acquired pneumonia, definitely oseltamivir is justified. So in summary, proper diagnosis can and early treatment can prevent flu complications. Empirical use significantly reduces lower respiratory tract related complications, reduces hospitalization, and even it reduces antibiotic use. It has been recommended by WHO, American Thoracic Society, and Ministry of Family Health and Family Welfare of India. They do recommend empirical use of oseltamivir. Thank you so much. Thanks to my colleague and Dr. Ravi and respected Dr. Jokesar and to the Hetero Health. Over to you, Dr. Jokesar and Dr. Prashant.
Thank you. So we have had an extensive discussion about influenza and the management, and Dr. Ketan has told about the KYC of this organism. Know your customer. So we know everything about the KYC. And Ravi has told ABC of management. So now we are prepared to fight with this particular virus. Of course, there are some queries in the minds of the listeners, and some of them relate to the rationality of management. Because, on many occasions, when a child comes, it's very difficult to identify what is the type of organism which has produced this cough, cold, and fever. So based on, which parameters, Ketan bhai, you would like to tell the audience as to one should take a decision about starting an antibiotic, antiviral, or doing nothing and wait. So what is your opinion about this?
Sir, we all know that the viral symptomatology includes watering of the eyes, running nose, throat congestion, mild cough, cold, and fever. If you have a family background of respiratory illness, this looks like a viral illness. Now, second, we look at the seasonality. If it is a February, March, or maybe July, August, and a serious viral in the family, if patient fits into category A, symptomatic treatment, follow-up second, third day. If he is deteriorating, getting category B or C symptoms, definitely antiviral oseltamivir is recommended. If patient comes to us with category C, like high fever, respiratory distress, and in the seasonal variability, then definitely oseltamivir or antiviral is recommended. Antibiotic should be used judiciously. When you have a viral respiratory symptomatology, antibiotic is not justified. Thank you, sir.
Thank you very much. In my practice also, I almost follow the same principles, and I also ask them to come for follow-up after about 4 or 5 days, so that I know that the illness is not taking a different turn. Of course, usually I do not charge patients when they come for follow-up, because when they come for follow-up, I am learning. I take it that I am learning. So I usually assure them in the beginning only that, see, you come and show me, even though it is viral, it is better that you show me, because we know some of these viruses have a biphasic presentation, and on day 4 or 5 some of them can worsen. So it is better that we warn them about the warning signs which you told, and also ask them to come for a follow-up. And then Dr. Ravi, there is a question about those viruses being detected by PCR tests these days. So what is your opinion about the children in whom we should go ahead with these tests, and how reliable are these tests in a clinical scenario?
Sir, if in day-to-day practice, as Dr. Ketan has already elaborated, that in most of the cases in OPD practice, it is mostly a category A, mild kind of illness, and we don't need any test. We just need a good follow-up, and probably it is done. In a patient who is in category B, then also we require some kind of a reassurance and treatment with antiviral rather than jumping onto investigation. In only cases with category C, most of them, which I would say they are requiring hospitalization, there is a rationality of investigating for viruses. And the most common test available is a PCR test, though it is quite expensive test. We can have a panel kind of a test or a multiplex test. These are expensive tests, quite specific and very sensitive tests. And the only disadvantage with these tests sometimes is a picking of commensals. So we can pick up some commensals from the respiratory tract and may be misguided with that, and probably may use unnecessary antibiotics or unnecessary medications. So we have to have clinical picture, seasonality, and the methodology of the test before we prescribe any medication for that.
Thank you very much. I will just add one or two points to that. Like, in case if you detect para-influenza viruses, then oseltamivir doesn't work on para-influenza viruses. One more additional point which I would like to tell our listeners is that if there are high-risk contacts of the child, like, a father who is diabetic or grandfather who is asthmatic or someone who is receiving long-term steroids, then it is prudent and wise to give chemoprophylaxis to the contacts of the child who is influenza positive. So this is very important. So we are coming to the end of today's discussion, and I'm glad that we have two Veer pediatricians from Surat. As they are from Surat, I will call them as Surveer pediatricians. We say Shurveer pediatricians, so they are Surveer pediatricians. Of course, the moderator is Mahavir because I am from Maharashtra. So, and hetero is associated with Oseltamivir. So it's a combination of all the Veers today. Anyway, with that, I must say that we have discussed a lot about this fast and furious virus with abrupt onset and high transmissibility and rapid progression and complications like ARDS. It can create problems in the life of a child. However, when we use oseltamivir quickly in an epidemiological situation for categories B and C, then we can always stop the progression and stop hospitalization and mortality. Of course, flu vaccination is very important, annual flu vaccination, along with the cough etiquettes, along with the Hasta Pancha Sutri, which we always say certain things related to the hand, like hand washing, hand shaking, to be avoided, use of handkerchief, keeping other at hand's distance, and avoiding hand touching. So, with that, I virtually say namaste to all our listeners. And it's of course not possible to give a handshake, but even if it is possible, please don't give a handshake even in physical meetings, because it will definitely prevent transmission of viruses, not only flu, but all the viruses which are transmitted by fomite transmission. So with that, I thank Dr. Ketan and Dr. Ravi, and also thank Hetero for giving us an opportunity to express our opinions about this disease, and hand over the proceedings to Dr. Prashant. Thank you.
Thank you, sir. As usual, it's very lively. I mean, the end and adjectives are super. I'm sure the audience has got a lot of insights into the management and the differential diagnosis and when to start oseltamivir and when not to. Importantly, when to do investigation and when not to, when not needed. Thanks all the audience who took time from their schedule and attended this. Thanks all the doctors. Thanks, sir. Thanks, Dr. Ravindra. Thanks, Dr. Ketan. And thanks, Nagadevi. Thanks, Samriddhi, for organizing this. Thank you, sales team of Vitro. And sir, we can log off. I wish you a very pleasant evening. So we do not know how many participants. The marketing would know subsequently.
Okay.
We'll let you know. I'll ask Samruddhi to tell you.
It was just for the knowledge.
Yeah.
Okay. Thank
Thank you.
See you tomorrow.
See you. Yeah.
In the night also we'll get oseltamivir.